warm welcome to iFocus Online Lecture 525, the 16th in Eye and Systemic Diseases. Today we have Dr. Aniruddha Agarwal from Cleveland Clinic, Abu Dhabi, to speak to us on multimodal imaging in systemic diseases. He completed his MBBS from St. G.S. Medical College and King Edward Memorial Hospital, Mumbai, finished his MS Ophthalmology from PGIMER, Chandigarh, did his fellowship in clinical research at Stanley M. Truson Eye Hospital from Omaha, USA. He's also done his surgical vitreoretina fellowship from PGIMER. He's a PhD holder from the Maastricht University, Netherlands. He's currently the associate staff physician in medical and surgical retina and uveitis setup at Cleveland Clinic, Abu Dhabi. He's been the former assistant professor at PGI Chandigarh. He's a recipient of several awards, including the Kataria Memorial Gold Medal Award from the Prime Minister of India in 2014. He's authored more than 290 publications and 40 book chapters. His key areas of interest lies in ocular imaging, retinal diseases, and uveitis. We're very honored to have you, sir, and over to you.
Thank you very much for the kind introduction. Thank you to the team of iFocus, Dr. Honavar sir, for this opportunity. And we'll go right into the presentation. So it's my pleasure to talk about multimodal imaging in systemic diseases. And we'll be covering a variety of entities which include beginning from vascular, infiltrative, and other pathologies. And when we talk of systemic diseases, we must understand that eye is definitely now proven, even through new technologies, artificial intelligence, that it can help in detecting a number of metabolic and other conditions by just looking at the images and taking some of the scans of the eye. The most important when it comes to the clinical practice is obviously the vascular conditions, because they have an immediate impact on the retinal vasculature, both arteries and veins. And so let's go through some of the vascular conditions that are systemic but affect the eye and have different presentations. One of the most important vasculopathies is systemic lupus erythematosus, and patients with SLE often present with a very progressive, devastating ischemia, and often this is bilateral. This forms one of the most common reasons for a non-infectious vascular occlusion, specifically arteriolar occlusion. Patients with SLE and related conditions such as discoid lupus or even drug-related lupus can have a very similar presentation, and they can have complete knockout of the capillaries, where you have very large vessels only visible, rest everything is completely with a non-perfused, and these patients can develop neovascularization. And despite adequate laser, sometimes these patients still progress and they have leakage and develop secondary complications such as vitreous hemorrhages or detachments. In these cases, typically a fundus photography, fluorescein angiography is enough for us to be able to diagnose the vascular changes and looking at the neovascularization and looking at complications resulting from the disease. So SLE, remember, forms an important entity responsible for these retinal vascular occlusions. White-centered hemorrhages, like seen in this picture, can be also observed. When it comes to arteriolar occlusion, and when it specifically branch retinal artery occlusion, Suzak syndrome must be mentioned, because Suzak is a condition with recurrent BRAO, and it presents with focal vasculitis along with other systemic manifestations which include hearing defects. Suzak syndrome is often bilateral, and again, sometimes the arteriolar occlusion can be involving a very small branch and may not be visible. So, a fluorescein angiography is really important to look at new areas of occlusion, and these patients need to be treated with adequate immunosuppression. So, if you see the fluorescein image here of the left eye, inferonasally, you have the area of blockade, and this may be missed on routine clinical exam. It may not be obvious. This is very similar sometimes to the arteriolar occlusions in viral infections like cytomegalovirus retinitis, and you can have arteriolar occlusions in other viral entities as well, but obviously they will be associated with areas of retinal necrosis. And so, like I said, this is the area of the retinal arteriolar occlusion. Now, this is a patient who was seen, and if you look at the macular area in both the eyes, let me go back to the image here. This patient has these characteristic folds in the macula in both the eyes. This is a patient who also has some vascular changes nasally, and if you see there, what appears to be sort of sheathing in the areas nasally, and this is a choroidal folds, vascular tortuosity, some kind of sheathing. This is sometimes seen in elderly patients in our clinic, and we often don't know what is the etiology for these patients. Sometimes they can present with vascular occlusions as well. In this particular patient, the fluorescein angiography showed a very subtle sort of macular leakage, and you have focal, vessel prominence, especially the major arcades, but no leakage. There is some peripheral questionable leakage on fluorescein. We don't know if it is really significant. This is the left eye of the patient. Again, some vascular prominences, staining, but not obvious leakage. So there is what I would say vasculopathy and not really a retinal vasculitis because there is no obvious leakage. Now, this patient has had, last year November had some OCTs, and on the OCTs, you see here that the choroid is not very straight. It's kind of irregular, sort of wavy form pattern, and there are some microcystic areas in the retina in the right eye. This is another scan showing you some of these choroidal folds. The left eye also in November had some kind of choroidal folds. Now remember, these are very common sometimes because of idiopathic reasons. So you can have idiopathic choroidal folds, and these are common in elderly, and they may be associated with hypertension. So for this patient, we don't know if it is inflammatory. This patient had, at that time, obviously the COVID vaccine was blamed for everything. Or is it really an insignificant finding and does not require any treatment? So obviously that's not the answer, because in these patients you have to investigate and find out what's the reason why you have choroidal folds. It could be metastatic, or it could be idiopathic, or simply it could be a uveal effusion. But in this case, we don't know the answer so far based on the imaging. Now, while the patient was being investigated and followed up, in December, things changed, and nothing much changed in the right eye. You see still the choroidal folds, but you see the left eye developed ischemic insult here. You see an arteriolar occlusion in the superotemporal macula, and you see the corresponding hyperreflectivity on the OCT and some amount of backshadowing on the outer retina. So the infrared image clearly shows you the area of the infarct. Now these patients, with a now complicated by an infarct, choroidal folds, definitely you have to investigate for hematological conditions. And so this patient was, this is another scan, slightly superior to the ischemic area. And you can say that there is a sort of a PAM-like appearance, paracentral acute middle maculopathy. Although, of course, this is a much larger area and not a classic PAM lesion. And so when you have the entire lab investigations, you can see here that the patient had a very high ESR and a bit low WBC counts, but there were mutations in the factor 5, and antithrombin activity was also suboptimal. So this patient had a procoagulable state. Now these procoagulable states can happen in the elderly from various reasons. It could be related to a hematological malignancy, it could be related to multiple myeloma, it could be related to even some mutations in the factor 5, although this patient was about 62, so you would have expected some changes maybe in the early life if it was genetic, but nonetheless you can have it at any particular age group. Now, when you find a patient with a perivascular choroiditis, capillary non-perfusion, especially in India, then of course systemic and ocular TB come very high in the likelihood, and the positive predictive value is very high. And so the presence of these perivascular choroiditis or vitreous hemorrhage neovascularization should be definitely, should raise the suspicion of TB. Um, so, you have multiple presentations of TB, and this is a very classic case of what was initially described as Eales disease. Eales disease or TB vasculitis. Often they have some lesions in the chest which are inactive. They may not have systemic active infection, but they may have chronic signs of TB infections like Gons focus, and sometimes they may have even bacterial streptococcus has also been associated with Eales disease. So they present with classic vascular occlusions, neovascularization, vitreous hemorrhages, and they require anti-VEGF treatment along with anti-inflammatory treatment and possibly anti-TB treatment as well. So these are the usual presentations. So you see focal vasculitis, you have this neovascularization, you have frosted branch-like angiitis with neovascularization. So young male with occlusions, bleeding, think of TB. Now, you can have these perivascular choroiditis in these patients, and so whenever you have perivascular choroiditis, please differentiate them from tubercles, because choroidal tubercles is part of the systemic manifestation of the meningeal TB or CNS tuberculosis. So when the patient has disseminated meningeal or CNS TB, patients can have choroidal tubercles, and they may also have vascular occlusions, but more commonly you see isolated choroidal tubercles. But if you have a perivascular choroiditis like this, it is mostly suggestive of a localized ocular manifestation rather than a systemic disease. So these patients, they often require immunosuppression and may not completely respond to anti-tubercular therapy. Behçet's disease is an important systemic disease, which is also a very inflammatory condition, which has severe comorbidities associated with CNS manifestations. You can have neurobehçets. You can also have ocular manifestations, and you can have other systemic manifestations such as fever and rash, and other mucosal involvement can be common in Behçet's disease. So Behçet's presents very early with arteriolar changes. It can present with arteriolar occlusions, and eventually venular involvement is also very common. Remember that Behçet's is an important condition with a non-infectious retinitis. So in the fundus image, you can see that there are yellowish lesions which are suggestive of infective foci, and this is not viral in nature. And because these by definition are usually partial thickness retinal involvement, they disappear with anti-inflammatory therapy. They don't result in scarring or significant damage thereafter. So presence of retinitis in a Behçet's patients does suggest severe activity and high possibility of neurobehçets. And you see here in the periphery, there is vascular occlusion, and this patient was treated by laser. So Behçet's forms an important systemic cause where you have ocular manifestation. So you must look at the retinitis lesions and differentiate them from infectious conditions. Sometimes you have inflammatory systemic diseases which present with changes in the eye, and this is the most common list, of conditions that you see. You obviously, sarcoid is an important condition closely resembling TB. Sarcoid patients can have disc involvement, optic nerve, bilateral optic nerve involvement, and with classic waxy, arteriolar arthritis or venular involvement, periphlebitis with Candleback's drippings. And these patients can have lung lesions, or they can have skin lesions of sarcoid, and they can have the erythema nodosum. They could have other neurosarcoid and other manifestations. And it's very common to have sarcoid in extremes of age. In young children, sarcoid should be differentiated from Blau syndrome, which is associated with cutaneous lesions. And in the elderly also, you can have the first presentation of sarcoid in the very elderly. Remember, they are usually quantiferon negative and MON2 negative, but there is a subset of quantiferon positive sarcoid. We already spoke about SLE, but there are other systemic vasculitis which have ocular manifestations, and these include Churg-Strauss, Wegener's granulomatosis or granulomatosis with polyangiitis, birdshot, and Behçet's disease we already spoke about. Birdshot can have some systemic manifestations. It is an HLA-A29 associated condition, but most of the effects are in the eye. Granulomatosis with polyangiitis, of course, is a whole spectrum where you have systemic vasculitis, and it's a leukocytoclastic vasculitis with changes in the eye as well. So another picture of Behçet's neuroretinitis, where the OCT shows you partial thickness retinitis and you have involvement of the papillomacular bundle. So an OCT through the retinitis lesion is often very highly suggestive. It's very different in appearance from a viral retinitis or a toxoplasma or lymphoma. And these patients present with subretinal fluid. And remember, it is non-necrotizing. So once the Behçet's is under control, there'll be no residual changes usually. We must differentiate it from rickettsial lesions. Like rickettsia presents with inner retinal hyperreflectivity and hyperreflective dots on the OCT, although clinically they may appear the same. Remember, rickettsia is a retinochoroiditis, so you'll have choroidal involvement as well. And choroidal involvement is seen on the OCT as well as on ICG. Now, we'll talk more about lymphoma, but you can have systemic lymphoma manifesting in the eye. So when you have a lymphoma involving the bone marrow or involving lymph nodes, it can metastasize. Usually it metastasizes to the choroid, but you can have retinal involvement with disorganization, dome-shaped retinal elevation, thickening. And all these changes are completely reversible after local intravitreal therapy with methotrexate or even rituximab. So lymphoma must be considered in patients who have such kind of an appearance on the OCT. And so OCT imaging and even autofluorescence is very important. On fluorescein angiography, they can have leopard skin appearance as well. Endogenous endophthalmitis is again a systemic infection. Now, remember, these endogenous could be bacterial or fungal. These are usually sick patients. If the patient has prolonged antibiotic therapy, fungal is more likely. If the patient has liver transplants or hepatic encephalopathies or disseminated systemic infections like sepsis, urinary tract infections, or isolated fungal infections in a different area of the body, they could manifest in the eye. And the classic appearance of these on imaging, if you scan through the lesion, would be like, for example, in Candida or even Aspergillus, you can have a rain cloud sign where you have thickening and exudates which are almost bursting into the vitreous cavity, and there is backshadowing. So this is a very classic presentation of endogenous fungal endophthalmitis. We come into the next part, which is neurological diseases. And neurological diseases are entities which can present, which are of course having not only CNS involvement but other parts of the body. Peripheral nerves involvement could be there, and you could have involvement of the intraocular tissues. So let's look at this case, which is a patient of changing diagnosis. In 2007, was diagnosed with bilateral iritis. In 2010, was diagnosed with left optic neuritis and treated with methylprednisolone. Now, in 2010, an MRI was suggestive of white matter lesions. So now, of course, we are now inching towards the diagnosis here in 2010. In 2013, the patient was diagnosed with Fuchs uveitis because of anterior segment inflammation and KPs. The only complaint patient had was floaters. There was no pain, no redness, no blurring in vision, and no scotomas or micropsias, metamorphopsias. So if you look at the picture and fluorescein, there is no obvious leakage, but there is mostly, anterior segment inflammation with KPs, granulomatous KPs, iris nodules, and AC cells. Left eye also showed KPs and some cells. Now, when you have a very obscure diagnosis, not sure, always better to do fluorescein. Sometimes you may feel that clinically there is some sheathing or some silver wiring of the vessels, but when you do fluorescein, there is no obvious leakage. And this is a classic sort of a vasculopathy, like we showed earlier in SLE. This patient is slightly different here because there is definite signs of anterior segment inflammation. So MRI of this patient, serial MRI comparisons, you see in the 3 years there are changes in the deep white matter lesions were present in this patient. Now, this patient was diagnosed eventually as multiple sclerosis. Multiple sclerosis can rarely be associated with uveitis. Mostly it is optic neuritis. But sometimes you have a situation like this patient where you have anterior segment inflammation, KPs, and sort of vasculopathy. It's not a very obvious vasculitis. And these are patients who are present a small subset of MS patients. A majority of them obviously are females because this is more common in females. And most patients have sort of an intermediate appearance, intermediate uveitis like appearance. And 15% may have anterior uveitis, which is resembling a granulomatous uveitis. So it's important to note that when you have this demographic presentation, along with changes like we described, it's better always to get MRIs serially and to look at the presence of any lesions which are white matter lesions. Sometimes you have systemic drug induced, this was a topic which was covered before, but sometimes drugs can be associated with ocular manifestations as well. So let me give you an example here of a case, a 45-year-old female who presented with multiple serous retinal detachments. Yeah. So there are lots of these deep white lesions in the choroid, and there is fluorescein leakage, and you also have these hyposyanescent areas on the ICG. So you see fluorescein shows pooling of the dye, and ICG shows you deep choroidal granulomas. This is the OCT appearance where you have subretinal fluid. Um, you see these choroidal granulomas very clearly visible on ICG. So this is a classic textbook presentation of VKH disease, which also has systemic manifestations, which include some neurological symptoms, meningisms, and you can have whitening of the hair and headaches. So remember, sometimes neurological symptoms come before ocular manifestations. But this is a very classic ocular presentation. And I'm going to show you another image here on the left. You see, this is another patient on the left where you have an ICG without any choroidal granulomas. And the OCT shows you the classic presentation, subretinal fluid, choroidal folds. You have these sort of, folds which and the compartmentalization, sort of bacillary layer detachment, suggestive of VKH disease. But the ICG is completely different. The right side ICG shows you the choroidal granulomas. So what is this? So remember, checkpoint inhibitors like nivolumab can also cause a VKH-like condition, uh, and you must sort of differentiate it from VKH, which is a systemic disease. And so sometimes newer drugs, can have similar manifestations. I'm sure partly it must have been covered in the previous a lecture on drug-induced ocular changes. But remember that sometimes these drugs, when they're given for systemic reasons, can also mimic ocular conditions such as VKH disease. Let's go to infiltrative disorders. And the first case here is of a 60-year-old Asian Indian female who presented with decreased vision in the left eye. Main complaint was cloudiness, but no pain, redness, or watering. There was some joint aches and trouble breathing. And you see here the fundus picture shows you some haze. Nothing, no retinitis or choroiditis was visible. So the thoughts here are we again dealing with intermediate uveitis? Is it sarcoid? The patient has breathing issues. So what would be the next step? And so you see fluorescein here doesn't show much. You don't see any obvious, I think none of the fluoresceins that we have seen have shown any obvious changes or leakages. So do you still think this is uveitis? Or, amyloid could be another systemic entity where you have these vitreous veils and membranes floating around. Amyloid protein now has a treatment. We have different sort of approaches for treating systemic amyloidosis. So if it is amyloid, of course, the line of management would be to do a diagnostic vitrectomy, get the birefringence, and treat accordingly. But is this amyloid? We are not sure. So let's look at the OCT. And now the OCT is showing you more information here. So you see these typical sub-RP knobbly lesions, and the autofluorescence shows you multiple hyper autofluorescent spots. This changes a lot, yes. So this image does change a lot of, and moves us away from amyloidosis and brings us closer to lymphoma, vitreoretinal lymphoma, which is a CNS disease. Really, it's an ocular manifestation of CNS disease, which is CNS lymphoma. So the next step, if I have to give you three options, would you do diagnostic vitrectomy? Would you treat with steroids or do a steroid implant? So obviously you will not go with options 2 and 3. The option would be to do diagnostic vitrectomy and an MRI. Now this patient had a long history, and just to cut it short, we did neuroimaging, and this patient again had T2 weighted hyperintensities in the deep white matter, highly suggestive of lymphoma, CNS lymphoma. A patient only had headache, but then the patient, the radiologist said that it is possibly ischemia. We don't know if this is really a malignancy in the brain, and for that, the only way is brain biopsy. But then CSF analysis, again, didn't show malignant cells, but the interleukin ratio was in favor of lymphoma. So in such patients, vitrectomy is the answer, but the sample is very, very precious. And cytology findings in this patient show degenerated or smudged cells. So you have to be very careful with the sample and should be processed in 1 hour. And in this patient, luckily, a lymphoblastic cell was identified in the dividing phase with large nucleoli and opened up chromatin. And the diagnosis of B cell lymphoma was established on flow cytometry. This is another patient which I will show you. The patient now, you can have sometimes a lymphoma involving the optic nerve head. And when the lymphoma is involving, or leukemia is involving the nerve head, please differentiate it from other common entities such as, raised intracranial hypertension, toxic neuropathy, ischemic neuropathy, because these patients have an irregular nodular appearance. And so they must be subjected to CSF analysis and neuroimaging. So this is a case of a young Asian Indian girl, a lady with unilateral disc edema and perivascular subretinal infiltrates. So this patient had a diagnosis of systemic lymphoma, again manifesting differently, optic nerve involvement, hemorrhages, and ischemia. Isolated optic nerve head lymphoma can be also there, where you don't have other vascular changes, especially common in elderly women. And please differentiate it from raised intracranial pressure or even cryptococcal infections or radiation. These patients often require multiple lumbar punctures and PCR. This is an optic disc photograph of a young girl. This is acute lymphoblastic leukemia. So you see a very raised whitish infiltrative lesion, voluminous lesion with vessels on top of it, with exudative retinal detachment. So these patients with systemic malignancies can have optic nerve involvement, and this can be a very massive involvement. And these patients require immediate systemic assessment and treatment for their leukemias. This is usually in the blast crisis phase of the leukemia. Another 21-year-old male with acute lymphoblastic leukemia, optic nerve infiltration. This patient also developed vascular occlusion, obviously because of the large optic nerve mass, and cherry red spot was visible with yellowish white infiltrates, multiple dot blot hemorrhages. So systemic investigations are really necessary. So with this, I'm happy to take any questions, but remember, this is a never-ending topic. We have many, many systemic conditions which have ocular manifestations. The list is expanding as more and more systemic conditions are being identified and retinal imaging is being advanced. But it is important to correlate, and often we find ourselves joining the dots for patients and finding out all these systemic associations to find something in the eye. And often you'll have other specialties depending on us for the diagnosis. Thank you very much.
Thank you, sir. Thank you for putting so many different parts of a puzzle all under one roof for us. So if it's okay, sir, can we take some questions?
Yes, please. Yeah.
Yeah. Um, okay. So how can we differentiate early and subtle lymphocytic infiltration of the optic nerve head from disc drusen on imaging?
So disc drusen would appear as, they would be usually hidden, or they could be buried drusen, or they could be on the surface. And doing an ultrasound with very high hyperreflectivity and autofluorescence finding of high hyperreflectivity of the drusen, you'll have multiple rounded drusen. That's usually the feature. And doing an OCT through the drusen will show you a very hypo center. It's not a very cellular lesion. It's a very hypo center with a surrounding hyper reflectivity on OCT of the drusen.
Mm.
Whereas a lymphocytic infiltration is a nodular swelling, which is whitish in color. It will be usually large, and it will not be as hyper reflective on the ultrasound, and autofluorescence will not show a distinct hyper autofluorescence. It might be a hidden, it might be hypo on the FAF imaging.
All right. Okay, so you mentioned about amyloidosis and that there are ways to treat it. Can you please comment on that, sir? What are the treatment options for that?
So recently, there is a for the against the anti TTR, ATTR, which is anti-transthyretin protein. There has been an FDA approval, I believe, of an agent which is a targeted immunotherapy, which decreases the ATTR levels in the body. I think it's mostly from a cardiology perspective, but I don't remember the name of the drug. But I think there are now specific immunotherapies against ATTR.
Okay, and they are available for use as of now.
I'm not sure world over, but here currently, in Abu Dhabi, we are acquiring the treatment for that. The cardiology
All
department
right.
has some collaborations whereby they obtain the drug.
Okay. Okay, sir. Okay. So can RNFL thinning on OCT indicate CNS demyelination in multiple sclerosis? Is that possible?
There is no direct correlation between CNS demyelination and
Mm.
RNFL thinning. So based on RNFL thinning alone, you cannot say that there is demyelination. Sometimes you may have significant demyelination with no RNFL changes. So there is no direct correlation. There are now AI models that predict the occurrence of various neurological diseases, but mostly these are restricted to Parkinson's or Alzheimer's. It's very difficult to predict a demyelinating disease using any even AI models in OCT imaging.
Okay, sir. Um, so is there any added advantage of Octa over FFA in diabetic retinopathy?
So I did not cover diabetes and hypertension because I would never finish. It's a systemic
Mm.
disease, obviously, with manifestations. Now,
Right.
OCTA in diabetic retinopathy, I remember only very selected cases where I do OCTA. Honestly, I
Mm-hmm.
have lost significant interest in OCTA in retinal diseases, specifically
Mm.
diabetes, because the only reason I would do is to look at macular ischemia and nothing more in the central macula. Of
Okay.
course, if you want to
Okay.
look for NVEs in a patient where you cannot do fluorescein, you can do. But beyond
Mm.
that, some people do it for looking at deep,
Capillary
capillary
plexus.
microaneurysms
Mm.
before they do focal laser. But again, I don't do that often. I think they are very much visible on fluorescein or even
Mm.
on infrared imaging on OCT. So I don't think
Mm.
there is any advantage.
Okay. Okay. Um, so can you shed light on any sort of systemic diseases where ophthalmic imaging can detect subclinical systemic disease even before symptoms show up? Can you think of any such instances or
So
conditions?
all of the diseases, like I showed you, MS, lymphoma,
Mm.
they all sometimes have
Mm.
presentation in the eye initially, where you can
Mhm.
have subtle changes like sub-RP deposits in lymphoma. They appear sometimes before any CNS involvement, and often
Okay.
months or years later, these patients end up with a large CNS lesion. And I have seen 2, 3 patients who were lost. We couldn't save them simply
Mhm.
because we had the sub-RP lesions of lymphoma. We kept saying that this is lymphoma, but the neurologist and the oncologist never believe, that this is
Okay.
lymphoma. So this is one important area which we must know, which has
Okay.
subclinical. Now, there are certain nephropathies like IgA nephropathy, which
Mhm.
present sometimes with subretinal drusenoid deposits. I
Mhm.
didn't show that, for lack of time, but they can have these immune complex deposits, and they can also be like, to answer your question, a subtle sign of systemic disease.
All right, sir. Okay. So what are the specific indications to go for ICGA in case of choroidal granuloma?
I would do ICG in all cases of choroidal granuloma. I don't
Okay.
see any reason not to do ICGA unless it's really not available. The reason why we do ICGA is to look at the extent of the granulomas. Fluorescein is not going to tell you how many granulomas are there. The other thing
Alright.
is the size shape of the granulomas will help you differentiate TB or from VKH. Sometimes there is a confusion between CSR and VKH. Both of them sometimes present with multifocal detachments. And the only way sometimes is doing ICG and looking at granulomas in
Alright.
VKH. And also
Okay.
sarcoid and TB, there is a differentiation of the shape of the granuloma on ICG.
Okay. So, sir, it would be safe to say that all choroidal lesions warrant an ICGA that
Yes,
we are
all
trying to
choroidal
investigate.
inflammatory lesions warrant an ICGA.
Alright.
Now, all
Okay.
choroidal retinal disease, like non-inflammatory, they may not warrant ICG. I'm not saying that you
Alright.
do ICG in all cases of CSR or pachychoroid. Ideally, you
Okay.
should,
Right.
but for uveitis, yes.
Okay. So what choroidal changes on extended depth OCT guide treatment decisions in inflammatory diseases?
Choroidal changes.
Yeah.
Choroidal changes usually signify systemic involvement. So if
Mm.
you have conditions where the choroid is definitely involved, it's a non-infectious condition, you should go in the direction for systemic treatment. Local treatments like Ozurdex or local methotrexate intravitreal may not work because that signifies it is a systemic disease. So it should be treated systemically. So if you have, for example, Behçet's disease or birdshot, where you have significant choroidal involvement, okay, so it
Mm-hmm.
is an indication for systemic. Similarly, where you have VKH, very high
Mm,
choroidal thickening, just systemic
mm,
treatment as well.
mm, mm.
But if it is just a CME or if it is a focal lesion, you can go ahead with local therapy as well.
All right, sir. Okay. Thank you, sir. Thank you so much for joining us despite some
Thank you.
hitches from your end. We really appreciate it. Thank you. Before we all sign off, just a couple of announcements. Our next class would be on the 1st of August. We will be diving into our new module of optics and refraction. And the first session would be on physical optics, properties of light, electromagnetic spectrum, wave theory, particle theory by Dr. Pratiksha Sharma. We'll see you all then at the same time. And before we leave, just 1 second. Is my screen visible?
Yeah.
Yes, ma'am.
To all our viewers and all the audience members over here with us. This is our call for Physical iFocus 2025 that is scheduled from August 10 to 17 at New Delhi this year. And this being the last week before that, it's your last chance to grab the last few seats that are remaining. You don't want to miss this chance, and you want to be there with all the stalwarts of the specialty. So hope to see you all there. Thank you so much, and we'll see you soon again.
Bye.
Bye bye. Thank you, sir.